Hello, I'm Roger McIntyre. I'm a professor of psychiatry and pharmacology at the University of Toronto. I'm also head of the Mood Disorders Psychopharmacology Unit, Universal Health Network, and executive director of the Brain and Cognition Discovery Foundation in Toronto, Canada. It's my pleasure to be hosting this set of lectures dedicated to improving health outcomes amongst individuals who suffer from mood disorders. And today's session is really an emphasis on the phenomenology, and more specifically, looking at the phenomenology of mood disorders, not just across the spectrum, but historically from DSM-1 to what's now called the research domain criteria, the RDoC criteria. So the objectives of this presentation are to, in fact, discuss with all of you the historical, the conceptual, nosological, and therapeutic implications of mixed features. More specifically, what we're planning to do is to look at both historical and contemporary conceptualizations of mixed features. Secondly, we're going to be looking at the implications for mixed features insofar as how to make a diagnosis of major depressive disorder or bipolar disorder in someone presenting with these commonly encountered features. And finally, how do we in fact improve health outcomes amongst individuals who suffer from mixed features? The reason why I've decided to focus on mixed features as in many ways, an exemplar of a phenomenology that really brings up historical, conceptual, nosological, and therapeutic dimensions is because mixed features cover a disparate set of dimensions of psychopathology across many, many centuries of description. For example, if we go back to the 1800s or early 1900s, many emissaries in the field described mixed features. Names such as Fallret, Kahlbaum, and probably best known as Kreplin, described mixed features. And what in fact was common across many of the early descriptions was a dimensionalization of mixed features. In fact, it was Kreplin that described the so-called unification hypothesis, the spectrum of unipolar and bipolar disorders, where all mood disorders could be conceptualized along a spectrum. And that spectrum would be either a disturbance in how people feel their mood, how they think, or their activity called volition. I call that MTV, mood, thought, and volition. And whether or not all dimensions were elevated or decreased or various permutations, combinations, individuals were categorized, if you will, along one of these dimensional constructs as having one of the mixed states. So Kreplin, in fact, described mixed states dimensionally, but tried to label it categorically, depending on whether your mood was up, your thinking was up or down, or your volition was up and down. The DSM-3 was a turning point in psychiatry insofar as the DSM-3 had really balkanized the unification concept into unipolar disorder and bipolar. Said differently, post-1980, when DSM-3 was introduced, we then now had major depressive disorder as a category and bipolar disorders as a category. And that was in fact the way things had been until 2013 with the introduction of DSM-5. What has in fact significantly changed with DSM-5 is, we could say, going back to the future. So in other words, what's happened is that there's been recognition that mixed features, that is, hypomanic symptoms while depressed, can affect individuals who have major depressive disorder or bipolar disorder. So what we now see in the DSM-5 is a new specifier called mixed feature specifier. And mixed feature specifier in conversational description refers to opposite polarity symptoms while depressed or manic. Now, there are some details as to which symptoms don't count towards the diagnosis, but the conceptual framework is opposite polarity symptoms occurring while manic or depressed, respectively. This is a reminder, in fact, that many adults with major depression can have hypomanic symptoms, and the presence of hypomanic symptoms does not, in fact, denote that the person has bipolar disorder. Now, a very separate typology known as the research domain criteria has been proposed by the NIH in the United States of America. And the research domain criteria is not a diagnostic instrument. It is an effort to provide a typology or a way of sort of describing and framing psychopathology along dimensions that are supported and subserved by discrete, or at least to some degree, discrete neurobiological substrates. The research domain criteria is a research tool. It's a research framework that has provided a framework for researchers, to, in fact, begin to look at neurobiological substrates. Why I bring it up during mixed features conversation is that all of the pathology that we see in the research domain criteria can, in fact, be seen in mixed features. Problems with anhedonia, so-called positive valence disturbances. Problems with fear response, so-called negative valence disturbances. Individuals with mixed features have very high rates of general cognitive impairment, probably why they're so functionally impaired. We know those individuals also have problems with social cognition, and as well as problems with circadian rhythms and arousal systems. So I like to refer to mixed features as, in fact, the 5-alarm fire, because if we look at the finite numbers of ways that the brain can manifest psychopathology, we see all of it in mixed features. So the DSM-5, which was launched in May of 2013, eliminated mixed states, the co-occurrence of mania and depression, and supplanted mixed states with mixed features. Clearly, someone who has mania or hypomania has bipolar 1 disorder or bipolar 2 disorder, and if they have depressive symptoms while manic or hypomanic, we call that mixed features. Conversely, while depressed, an individual with either bipolar 1, bipolar 2, or major depressive disorder could in fact have major depressive episode with mixed features. So this is in many ways a lot like Kraepelin described, that is the calculus, the dimensionalization of the phenomenology of mixed features, and where you fit in along these dimensions really depends on how many symptoms you have. We learned from the DSM-5 field trials that the more depressed people are when they present to healthcare providers, the more likely it is we're going to have difficulty making the diagnosis. In other words, the inter-observer agreement for major depressive disorder in the DSM-5 was at 0.28. For bipolar 2 disorder, it was 0.40, and bipolar 1 was 0.56. So what this tells us is that the more depressed or more predominantly depressed patients manifest, the more likely it is that we're going to have difficulty establishing the diagnosis, and depressed individuals often present with mixed features. Mixed features are common, but before I get into that, let me just say a few words about why we need to think about mixed features. We know that mixed features in depression or bipolar disorder are more likely to be associated with a younger age at onset, a more higher rate of chronicity, higher rates of non-recovery, and also very much higher rates of recurrence. We've also begun to learn that individuals with mixed features are more likely to have suicidality, specifically attempts at suicide and lethal suicide. And there's a fairly convincing argument to be made that mixed states could be the most lethal phenotype in all of psychiatry. We've come to learn there may be some gender distribution, insofar women may be more likely to be affected, and we are certainly much more likely to see mixed features in some of our pediatric or younger patient populations. Of particular interest to myself is the overlap of mixed features with concurrent psychiatric and medical comorbidity. For example, individuals who abuse drugs or alcohol are more likely to have mixed features, and vice versa. And as well, recently our group has learned that people who have mixed features may be more susceptible to cardiovascular disease. We would hypothesize that individuals who have mixed features are more prone to cardiovascular or metabolic disorders because of the changes that are occurring, including but not limited to neuroendocrine, pro-inflammatory, autonomic dysregulation, as well as excess catecholamine drive, so often seen in these patients. More recently, we've had a look at the economics of mixed features, and what we've learned is that individuals who have mixed features are more likely to be off work, absenteeism, decreased performance at work, presenteeism. They're also more likely, in fact, to utilize healthcare services across primary, secondary, and tertiary centers. Moreover, individuals with mixed features are more likely to have disability payments given to them. What is the essential feature of mixed features? Well, in my experience, which would cohere with the clinical evidence that's been reported, is that overactivation or overactivity of thought, of feeling, and of behavior is in fact the essential feature of mixed. These individuals often complain of anxious agitation, hyperactivity, often racing, distracted thoughts. I want, however, to remind you that distractibility, insomnia, indecision, anger, and agitation don't count towards mixed features according to the DSM criteria, but these are commonly encountered. So whenever we encounter people who have depressive symptoms, we're paying very close attention to whether that person has activation, racing, distracted thinking, or they have elevation, in their mood state, often manifested as a dysphoria. It's not something that they enjoy. It's often what we call ego dystonic, is there increase in activity that may not be goal-directed. We know from some lines of evidence that individuals who have major depressive disorder with mixed features, just like people with bipolar disorder with mixed features, are more likely to evince a less favorable illness presentation, more severe, more comorbidity and suicidality, lower rates of recovery, higher rates of chronicity and recurrence. Moreover, the disability and the impairment in patient-reported outcomes like function and quality of life is much more profound in this group. The rates of mixed features vary widely. In some ways, it's like how long is a piece of string. It depends how you define it. But it depends on the study. It's ranged from 10% to as high as 94% in the description of the prevalence of mixed states. More recently, our group in Toronto, with colleagues at Cleveland Clinic, have looked at the prevalence of mixed features in both major depression and bipolar disorder. According to the DSM-5 criteria, what we found is that about 25% of people with major depression and about 30 to 35% of people with bipolar disorder, in fact, have mixed features according to the DSM. So very common indeed to see such people. We've also learned that if people have mixed features during a depressive episode, it may not mean they have bipolar disorder. According to a longitudinal study that reported recently, it was revealed that about 20% of people with mixed features will eventually declare themselves as having bipolar 1 or bipolar 2 disorder, which means that 80% will retain the diagnosis of major depressive disorder despite the fact they evince mixed features. So in other words, mixed features is an alert that the person may have a covert bipolar presentation, but it does not in fact allow us to say it's prima facie evidence that they have bipolar disorder. Other research from Europe would in many ways replicate the previous study I just referred to, insofar as individuals who do have major depressive disorder and mixed features have a higher probability of going on to declare bipolar, but again, majority retain the diagnosis. We wanted to, in fact, begin with this framework and describe the phenomenology of mixed features. I now want to just change directions and speak to what's called probabilistic factors. How would I know if a person who has depression has bipolar disorder? Well, there is no biometric or biomarker way of really ruling this in or ruling this out. So it's based on a set of probabilistic factors. And we know that the probability is higher the person has bipolar disorder if, while depressed, they exhibit so-called reverse vegetative symptoms or atypical symptoms. They're exhibiting psychosis or more severe depression. I'm also very attuned to whether patients have high levels of agitation and anxiety. We've learned also that patients with chronic depression or in female patients of reproductive age, pregnancy-associated or postpartum depression certainly alerts us to the possibility of underlying bipolar disorder. Seasonality, of course, has been described for years as being overrepresented in bipolar patients. And we've also learned that many patients with bipolar have patterns of comorbidity, psychiatric and medical, that overlap with but are slightly different than people with major depression. For example, people with bipolar have higher rates of drug and alcohol misuse on average, and also have higher rates of cardiometabolic disorders as well as thyroid deficiency. Finally, family history of psychopathology is certainly much more common in people who have bipolar disorder. And so often people who have bipolar disorder will tell us that they've had early childhood psychopathology or an earlier age of onset of illness. When we look at the actual phenomenology of those mixed features, when people who are presenting with depression are concerned about, what consistently comes up again is this issue of activation. Patients complain of distracted, racing thoughts, a general sense of dysphoria and agitation. We need to make sure this is not a consequence of drug and alcohol misuse, a consequence of ADHD, and not a consequence of some other type of cause that may be in fact masquerading as mixed features. What I in fact really like to emphasize is that about a third to 40% of patients who are depressed will have mixed features. And again, it's that agitation, elevation, racing, distracted thinking that is so common in this particular group. From a treatment perspective, what we've learned is that people who have hypomanic symptoms while depressed do not appear to have as reliable antidepressant responses. In fact, we know they can respond to treatment, but not as reliably. There are data to indicate in bipolar disorder, for example, that if people have depression and mixed features, they're much more prone to have hypomania or mania mobilized by the antidepressant. So said differently, if there's persons, in fact, who should not receive antidepressants, who have bipolar disorder while depressed, it'd be people who have mixed features. Data from the STEP BD group has consistently shown that the efficacy for antidepressants, particularly in mixed features, has frankly been underwhelming. And we know that the recovery from mixed depression in people who have this particular presentation is much less favorable than recovery that we see in pure mania. What we've also in fact learned is that if you prescribe antidepressants to people who have major depressive disorder mixed features, they don't seem to respond as well. We said this earlier, and in fact too often patients have what's called a misadventure. They report intensification of anxiety, agitation, and racing thoughts, obviously something that they don't wish to experience, and something in fact that seems to be highly associated with antidepressants in some people. There's a paucity of research with antidepressants and bipolar disorder. There's been some consensus statements, and where there is consensus with the use of antidepressants in bipolar disorder is not to use them in people who have depression with mixed features. In other words, people who have hypomanic symptoms while depressed, they probably should not be given antidepressants out of concern it could exacerbate their situation. Atypical antipsychotics have demonstrated efficacy in mania as well as in mixed states. We know that atypical and conventional antipsychotics can suppress elevation and agitation, and it's no surprise that these agents are being frequently prescribed for people with mixed features. Between the anticonvulsants, divalproex, carbamazepine, lamotrigine, the agent that's been studied most in mixed features has been divalproex, which not only demonstrates efficacy, but in many studies has shown superiority over lithium in treating patients who have mania with mixed features. Data now exists for several of the atypicals. For example, lurasidone has demonstrated efficacy in treating bipolar depression with mixed features. And we know that ziprasidone has also demonstrated efficacy in mania with mixed, and more recently in patients with bipolar II disorder or major depressive disorder with mixed features. What's interesting is that there's been a recent publication in major depressive disorder demonstrating that an antipsychotic drug, lurasidone, as monotherapy, could be effective in treating major depressive disorder with mixed features. Is this an effect that's confined to lurasidone? I'm doubtful that's the case, but lurasidone is the only agent studied so far in major depression, and we certainly look forward to many other new studies being done with other atypicals that possess antidepressant properties to see whether they can in fact improve outcome. Other atypicals like olanzapine, risperidone, and even acenapine have been studied as possible treatments for mania with mixed features, and in the case of olanzapine, depression with mixed features. Unfortunately, however, with treatments like olanzapine and risperidone and quetiapine, we've had problems with sedation and weight gain and metabolic changes for many of these agents indeed. Finally, electroconvulsive therapy seems to be very effective in mixed features. The jury, frankly, is still out with respect to TMS for mixed features. There's some preliminary evidence that looks very promising, but we've not seen, in fact, the convincing data just yet. A recent survey by our group revealed that people who have mixed features are very often prescribed antipsychotics or lithium or anticonvulsant mood stabilizers along with antidepressants. So this group is not infrequently receiving polypharmacy. The recent publication of the Medicaid guidelines from the USA, based out of Florida, in fact gave special mention to how we should be selecting and sequencing treatments for mixed features in psychiatry. This was a set of recommendations that was arrived at through a very multidisciplinary group: clinicians, actuarial experts, people expert in public policy, advocacy, academics, researchers, got together, in fact, tried to come up with a best practices approach to mixed features. What was agreed upon is that antidepressants still need to be considered in major depressive disorder with mixed features, but not in bipolar depression. And in some cases, there could be a role for more mood stabilizing agents like lithium, or maybe the atypical antipsychotics as first-line agents in individuals who have mixed features. We shouldn't forget that there's other comorbidities that need to be addressed. In many cases, psychotherapy would be entirely appropriate when first-line treatments for mixed features are insufficient on their own. In fact, I would see the use of social rhythm therapy and sleep therapy along with aerobic exercise and dietary manipulation, lifestyle improvement, or lifestyle enhancement in terms of healthy lifestyle, as all important adjuncts to medication in treating patients with major depressive disorder with mixed features. Surprisingly, in 2017, we still do not have sufficient evidence regarding conventional antidepressants and what's their role in treating major depressive disorder with mixed features. So to summarize, mixed features are very common in psychiatry. Mixed features have historical, conceptual, nosological, as well as therapeutic implications. We know that mixed features identifies a subpopulation that is a much more unfavorable illness presentation, course, and outcome. Mixed features can affect not only people who have bipolar, but can also affect people with major depression at a substantial percentage indeed. As far as treatment approaches are concerned, I would encourage you to, in fact, be aware of various guidelines that have been published on this topic and inform your treatments with the guidelines that we currently have. The guiding principles are screening and measurement and using targets in terms of what you're treating, and also, in fact, be very cautious in using antidepressants in bipolar depression, where they have mixed features. And in major depressive disorder, antidepressants still can be considered for those with major depression mixed features, but also there's growing interest in the potential application of lithium, maybe atypical agents and other mood stabilizing agents for this particular phenotype. Finally, the research domain criteria is a very new way of thinking about the dimensions and the neurobiology of not just mixed features, but psychopathology in general. And it's hoped that future treatments will be more domain specific, that we can improve the quality of life and the function of people who suffer from this particular condition. Thank you very much for joining me for today's session.